Good afternoon and welcome to the SNOMED International Expo. This is the session entitled Enhancing Clinical Practice and Outcomes. And this particular presentation is brought to us by E Farre-Maduell. Eulalia is a physician, senior researcher, working in the text mining unit of the Barcelona Computing Center. And today she's going to talk to us about working with NLP systems and some of the challenges when faced with differences in semantics and how to reporting on attempts to normalize using ICD-O and SNOMED. And she'll explain all the details to you. Thank you.
Thank you very much. I don't know if you don't hear well, please tell me. I think my talk fits quite well into what Dr. Igali has said. Maybe there are other pathologists in the room. Please be lenient. I'm a pediatrician and I'll try to do my best, but I have done this work with people in my group. No? No. So I will talk first about the relevance of cancer pathology. I know probably some of you are not physicians. Then briefly, what can biomedical text mining and NLP do? We don't work with imaging, we work with text always. So we work with pathology reports, case reports, etc. We have done a project on cancer pathology text mining, which is called Cantemist. You'll see some examples. And I will talk about the normalization challenges with Dr. Igali has all mentioned many of them already. Some of the results we have obtained when comparing ICD-O with SNOMED and with NCI Thesaurus, and the conclusions and future implications, because as Dr. Igali has also pointed out, the diagnostic of cancer is changed a lot and is having much more genetic component and biomarkers, etc. So, well, we all know how devastating cancer can be. It's the second cause of death globally, but the fact is that it kills a lot of young people. No, cardiovascular disease is the first cause, but it kills a lot of older people. But we all know people that have had breast cancer, prostate cancer, lung cancer. These are the most common cancers, which of course they are in numbers the most important. But a statistic tells us that there are cancers that are more rare, but that in numbers, when we accumulate populations, they also kill lots of people. And these are called cancers in the European Union. If they have an incidence of 6 per 100,000 or less, it's a rare cancer. So these are sarcomas, etc. And last but not least, and September is the Childhood Cancer Awareness Month, we have the childhood cancers, which are devastating. You know, they are two-year-old children that have leukemias, but they are fortunately also rare cancers. So what is cancer pathology? I dare say that is the study of human tissue. So a surgeon might take a part of a tumor, an abscess, whatever, and the pathologist studies it under the microscope or on a computer. And as we know with cancer, apart from also blood cancers, when you have the diagnosis of cancer, it's because you have the result of the biopsy that tells you this is a node cell cancer, this is a ductal breast cancer, etc. So the biopsy is sort of the gold standard to diagnose cancer. So the pathologists observe this tissue and they write a report about it, and we work with reports. So why is it important that we implement artificial intelligence methods in human pathology? I think one of the most important things is that as medicine progresses, more doctors are needed. And we see over all the world that there is a need for doctors everywhere. So we need artificial intelligence to supply this lack of manpower, let's say, and woman power, of course. So artificial intelligence can screen images. So it's not clinically implemented totally, but it will be soon, hopefully. So we all know that there are screening of breast cancer. So the pathologist will only have to look at the ones that have something, not at the 100,000 that they receive every year, or Papa Nicolaus, or whatever is done. And it can assist also text mining and natural language processing in leveraging the pathology reports. And text mining, so natural language processing refers, for those of you who don't work in natural language is the language we speak, the language we write. When I write a letter or an email to my son, or when I talk to you, or when I write a scientific paper, or when a writer writes a novel. All this is natural language, and this is what we work with at our unit. So we have this unstructured text, which in this case are pathology reports or reports of people with cancer. And it's this language that the pathologists have written, or the oncologists. They write, you know, a woman, 46-year-old, presenting this mass in the breast. This is the unstructured text. The structured part would be hemoglobin 6. This is the structure. These reports are unstructured. What we want to do with natural language processing is structure this data to leverage them. So, in this case, for human pathology of cancer, we have implemented name entity recognition of things that have to relate with histopathology of cancer. But name entity recognition, in this case, is of pathology. But this is a procedure, or we also can have countries, whatever. This is all SNOMED, this is a very rich ontology. So what we do is recognize the entities, and then we want to normalize them. So then, if the hospital we work with wants to share data with Dr. Igali's hospital, having the codes, we know that we are talking about the same thing. And importantly, why do we want to do that? It's not because we have fun working, which we have, but because we want to help people and ourselves and the health services in the prevention, the screening, the diagnosing, the classification of patients, the treatment, the follow-up of patients with cancer, and research.
Sorry to interrupt you. I think there's trouble with people hearing you.
Yeah, it's because I don't see the
I know, if you had is there a handheld microphone that would be available? That might be better, because I see you want to point to things on your slide.
Then you can walk around it. There you go.
Thank you.
Okay, so the project we have done is we took around 1,300 oncology case reports, and we annotated them manually. The annotation was done by myself. I'm a physician and a cancer biologist who's very well trained in annotating and coding in SNOMED. However, we found that some of the tumors were very difficult. There were lots of mixed tumors, germinal tumors, blood tumors that we felt a bit confused about. So for that, we had the assistance of two tumor pathologists from a hospital in Barcelona that has around 800 beds and is a referral center for difficult patients. So we did firstly the normalization of this 1,300 with ICD-O, which we know is the base for SNOMED CT in morphology of tumors and also of NCI thesaurus. We only used the morphology codes, not the location codes of the tumors. So we have published the annotated guidelines because we know only the people that when see text, it's very difficult to know where you have to start and finish an annotation. So for reproducibility, we do very strict guidelines that we follow when annotating, and we organize a competition. So we ended up with over 16,000 annotations, and we use more or less half of the codes of ICD-O. There were all sorts of tumors. Okay, this is an example. The corpus was all in Spanish. It's done in Spanish. It's also available, freely available. We have here the corresponding annotations that we did, and the annotations were done following these guidelines. So what we did for the project before we came here, we wanted to know, we already had used SNOMED CT, but we wanted to know how these three ontologies compared. So we took three very big ontologies, knowing that natural language is always richer than the codes. You know, what the pathologist writes is rich. And as our pathologist told us, is that every word can be very important, either now or in the future. So you have to be as comprehensive as possible when you take a code. And we wanted to know which elements the codes miss, to see how the ontologies were doing and how exact we were when we had a code and said this person has that, because we knew some elements could not be there, like keratinized or something like you mentioned before. So we aim always to obtain the most specific code for the mention. Again, for SNOMED CT, we only use pre-coordinated codes because, as we know, we want to automatize that. And automatizing the pre-coordinated codes for histopathology of tumors is difficult enough. If you add post-coordination, well, it's a non-territory still. We use preferred terms and synonyms, and we use, when possible, morphologic abnormality. But sometimes, as for instance, lung cancer, sometimes we had only as a disorder. But we prefer to take, we prioritize morphologic abnormality. So what we found at the end of we took 270 random mentions to normalize. And we normalized, sometimes the codes were very precise, but we know here in these terms, like you see, they all have the same code because they say things that don't have a specific code. So we put the general code. We couldn't do best. For example, for inflammatory tumor, we didn't find a code, or for fibroblastic tumor, we didn't find a code. So if you believe the code of neoplasia, they are telling you lots of different things. And this is a shortcoming, I would say, of the ontology, probably. Of course, some of these you could do with post-coordination, but we are not there yet, I think. So other things that we found during what we found when we were normalizing this is that, for instance, and it makes sense, the most common tumors had lots of possibilities. Very unfortunately, breast cancer is too common, so you can find the quadrant of the breast where the tumor is, etc., etc. If you look for a rare tumor, the possibilities are much less. And if you look for very rare tumors like this extracranial rhabdoid tumor, you don't have even one result. This is a very rare tumor of a child. And why is this important? Well, it makes a lot of sense because what we mostly codify will be a breast tumor on the left breast, blah, blah, because this is the most common. These codes that we put when we normalize, it helps a lot for rare diseases, because then I can share data with Peru, with the States, and with Thailand. And if I don't have a code for that, there are these two children, one in France and one in Italy, and doctors won't know what to do for treatment, etc. So it's important that these also have lots of possibilities to work with big data, to share it with globally. So another thing is that the complexity of the names of the tumors. So I had colloid carcinoma, no? And as a pediatrician, I looked for colloid carcinoma. I didn't find it. But in fact, you find it when you look for mucinous adenocarcinoma. If I'm not a pathologist, I'm not sure that I'm putting the right code. So I have to consult a pathologist for that. Also, the names change quite frequently, apart from being very complex. So now we are calling a type of tumor of the uterus, uterine corpus undifferentiated sarcoma. But in fact, only in 2014, it was called high-grade endometrial stromal sarcoma. These are very different names. And this is only one rare tumor. You know, we have lots of tumors. They keep changing names, and it's very difficult to keep up with that. And you look at the literature from 10 years before, if you are mining the literature, how are you going to find all these different names, etc.? It's very complex. We have found that from SNOMED, ICD-O, and NCI, NCI has a description of the disease, which sometimes is very helpful. So if we have large cell atypical Ewing sarcoma, and I only find atypical Ewing sarcoma, the definition tells me that in fact, this is a tumor that has large cells. So I'm feeling quite confident of this code. The same for another tumor, the fibrolamellar liver carcinoma, that the definition tells me it's in the liver, so I put very confidently this code. If I don't have the definition, I have to start looking at the literature, etc. So what we did, we took these 270 mentions and we looked at the things that the ontologies didn't give us. We did that with the 3 ontologies. So the first code here that is exact, you know, we have tumors of the gastrointestinal stroma, and the code is exactly the same, exact. Okay, but the other tells me that it's adenocarcinoma with of the bowel and that has metastasized to the liver. So I put that the behavior, which is metastatizing, is not there, and the topography of the metastasis is not there, and so on and so on. We looked at all these things that the codes were lacking for the 3 ontologies. And what we found is that we have an exact code in a bit less than half of the mentions that we had in this corpus. And interestingly, one of the major problems was with specific histology details that were not in that code. Other was the behavior, if the tumor metastasized, the grading of the scale, etc. Here, we'll see some histology things that were missing. So in the text, we had that the tumor was invasive, ductal, tubular, epithelial, multicentric. All these mentions were not captured by our codes, would have had to be post-coordinated. However, I was quite happy with the 3 ontologies, and we have to say that, for instance, SNOMED, if I have I don't see it very well, but infiltrated ductal carcinoma of upper quadrant of the left breast, etc., had a specific code in SNOMED. So it was quite good for many of them. So the conclusions are that the annotation and normalization of the histology of tumors is quite complex. So in our group, we also normalize diseases, occupation, geography, and histopathology is very complex, really. That SNOMED is useful for cancer pathology, but it's only exact in approximately 50% of the dimensions of tumor pathology. And that looking at the future, where we are having molecular diagnosis, liquid biopsies, genetic genomics, immunochemistry, some of these things exist already. Some will be implemented, surely in the next 10 years will be commonplace. We have to make sure that these ontologies or the optimal ontology can capture all that in mentions, because it's not only what we see under the microscope, what will tell us what cancer we have, but all these things will be added. And finally, why do we do this? Because cancer, as we know, is a severe disease that kills a lot, but it's pioneer in the sense of personalized medicine. So oncologists have these tumor committees, and they try to see with all these techniques, they individualize patients that on the surface have the same tumor, like prostate, breast, etc. And using all that, they differentiate patients to give the best treatment, the treatment that will improve survival, and the treatment that will have less adverse effects on that person. And this is extremely important. Finally, I want to say thanks to my colleagues, Antonio Salva, and my boss, Martin Kralinger, Gloria Gonzalez, which is the biologist that has helped me, and our pathologist, Tony Martinez and Leo Rodriguez, Hospital Clinic, and all of you for listening. Thank you very much.
There's time for some questions if there are any. Oh, the microphone. Yes, that's right. Thank you.
So thank you. This was very good, but I think the one major problem is that pathologists tend to make ambiguous texts. So pathologists make a text which is ambiguous. Pathologists use a nomenclature which is not easily to change into or to map to SNOMED. So I wonder whether it would be better to ask pathologists, or to enable, not to ask, to enable pathologists to directly document in a structured way. So you have all the codes you need.
Well, I don't know what your background is, but I'm a physician, and I think, well, this is an opinion, and you can tell yours then. I would be very wary in not letting the doctors write what they feel, what they see, what they observe, and only code.
Yeah, but
I
I'm a
think
pathologist. I think it's possible.
You think, I'm as a pediatrician and looking at a child that comes to me and tells me about a problem, I wouldn't want to deal only with code. Some will be code, some, I'm a bit reluctant of this. I think that, yes, we'll tend to do it more, to adapt to these ontologies, but it cannot be like that completely. I would feel quite insecure. It could robotize medicine a bit. I don't know. I don't know what do you feel about that? About making doctors just use codes or?
No, don't you shouldn't see the code, but you have the morphologic abnormalities, and you just select what you see. So you have this micro abscess, you have this hyperkeratotic nodule, and that's it.
That's what I was saying. You know,
Okay.
it's very good.
Well, if you pathologists feel like that, I cannot say anything.
We have to put our hands up, because I noted your presentation that one of the missing bits was in the ontology the word invasive. Okay, I think it's redundant. If you call something cancer, it means invasive, and you have to specify the other way around, then it's not invasive, and we call it in situ. And these steps, if we can be a little bit better of actually getting rid of these redundant meanings, yeah, I think that may help. But I agree with Thomas on the things that if you have the very nice language of talking about carcinoma in all detail, it may not be good for the patients. And where I see the sort of potential convergence between the two things is the synoptic reporting, because if we use the cancers, and it's I give it to you, it's not developed for rare cancers, but if we use synoptic reporting, when the codes are already associated with the various features like vascular invasion or margin involvement, or what you also missed, I have seen in your presentation, is the location of the metastasis or the origin, which is being developed at the moment by SNOMED CT. I think we are getting one step closer and probably can close the gap for the rare cancers as well.
Yeah, I know it's developed. I mean, at the moment, it looks a bit arbitrary. You find that for some cancers, not for others, but I guess it's a work in progress.
Indeed, and as you showed us, the breast cancer is very well sort of detailed as one of the frequent cancers. But if you look at those codes, all of them are findings and these are their codes, not morphological abnormalities. And we need to change this thing because we need to probably make sure that we are talking on the microscope means something in the diagnostics as well.
Yeah.
One more question, I think, Terence, we have time for. Oh, I don't know. There are two. I only see one hand. Sorry. I only saw one.
So, but what you describe is more that they are missing codes rather than the algorithm is not good enough. But and oh yeah, and so they are missing codes actually. So it's the coding system that has to be improved.
I mean, more than missing codes is that the code doesn't capture the whole range.
Yeah, I think this probably links back to one problem. The FSN doesn't contain the full specified name, doesn't contain the bit. And you showed a nice example of where you found the colorectal cancer on the synonyms. And I think that's where we can make some strides within SNOMED CT to make sure that the synonyms are captured.
If I could just say on the SNOMED end of things, we're actually working right now to update based on ICD-O 3.2. We have the Cancer Synoptic group working. And by the way, you can always send in a request and ask for a synonym to become the preferred term, if that's actually the way you call it. I was interested to hear what you said, though, about pathologists renaming things over time. That's our challenge. We need professionals, if I may dare say, to harmonize your content and agree on it, and then we'll put it into SNOMED and everybody will know what it is, but that's the ideal world.
And
sorry, another
yes,
question.
regarding the mapping between ICD-O and SNOMED CT, so are there still a lot of missing terms in SNOMED CT compared to ICD-O, or is it automatically added to SNOMED CT when there are new terms in ICD-O?
So we have a map to ICD-O 3.1, and if I may say, we want to do the map to ICD-O 3.2, but we've had difficulty receiving the files. It's a very difficult process to do that, manually eyeballing things line by line. So we are doing it, but it will take a long time. If we got a file upload, we could do it automatically, but we don't have the file. I'll say no more.
Missing references done with the solution on that, on how we can do it.
Yeah. So
Yeah.
with the graph note, like traverse all the obviously the preferred term and synonym, and then they link them back to and so using graphical traversal. That's how I look up using deep learning all these synonyms to make my life easier, because I ran into the exact same problem.
It was there by a different name. Yeah.
You're not running into the same problem that you want to have with detailed spots. Because where do you start? You are creating in the same way in a complete report with tumor plots, etc. Just going really to the details. So I think that's why it's not important. It's just one of the brilliant things. But then is this standardization. Because I was wondering, as a clinician, how many synoptic reports do you receive with your clinic? How many?
Synoptic reports, standardized.
I'm working at clinic now, but I don't think it's a serious thing at the moment.
Oh, no, that's why.
Yeah, exactly.
No. You get a written report that's actually everywhere on the same place, the same items, and you always know it's complete report. And on the backside, there you have all the problem.
Yeah.
And there is a part that's still missing.
Yeah.
Okay, I thank you. And I really like the discussion stimulated here, but we do have to go on to our next session. So thank you, Eulalia, and the audience participation. Thank you.